All right. So I went through this basically reading that to you. And I'm going to start with skin problems. Systemic diseases like diabetes can cause dryness of skin due to peripheral neuropathy, which comes in three forms. Autonomic, which is the automatic functions of your body. And then it comes in sensory and motor. And so when it hits the autonomic functions, your body doesn't secrete the oils and things that it normally does to keep your skin moist, and you'll see skin dryness. Ligaments weaken as we get older, and flat foot deformities stress our ligaments. And so many times that causes pain and discomfort and arthritis. So once your ligaments get stressed in different directions, you're moving that joint in directions that it's not made to move in, and you get stresses throughout the joint from pulling ligaments and bone on bone, and you'll get arthritic changes. Muscle mass loss can be neurologic, from neurologic diseases or radiculopathies or degenerative neurological diseases, but they can also be from endocrine, diabetes, and vascular. So it causes weakness and then muscle imbalance and dysfunction. And lastly, the itises, which is swelling. And we think of these as the inflammatory responses that affect joints, rheumatoid arthritis, psoriatic arthritis, the HLA-B27 antigen diseases, which many people who suffer from these are familiar with. And they include ankylosing spondylitis, rheumatoid arthritis, and a number of other arthritides. So those are the things that can cause trouble. And skin, sometimes hair loss is normal, but sometimes it's a sign on the foot of poor circulation. You commonly will see it with thinning of the skin in poor circulation. And skin loses its oils. We spoke about that, and becomes dry. With vascular problems, you'll often see hemosiderin deposits or brown pigments on the skin. And this is commonly seen with venous disease.
Hebron.
Calluses,
Did you make
or
good money on it?
hyperkeratosis, we call it, is a protective mechanism on the skin due to pressure areas, but can be troublesome and painful
From Jewel.
because they build up too thick due to increased pressure.
We need to tell Joe Fabris to mute himself.
And then last but not least, nail funguses, which we often see fungal nails, which become thick and sometimes dystrophic. And nail pathology comes basically in two forms. One is infectious from fungus. The other is from heredity. In the heredity form, you can't change. The only thing you can do is get rid of or remove the nails. Fungal nails can be treated, and there's a number of ways to treat it, including oral antifungals, topicals, and just debridements, or any combination of those. And this is an image of dry skin, and dry skin is fragile, it's delicate, and it's very thin. And you'll see corns on them sometimes, or this one has an ingrown nail, and it'll become brittle. Dry skin can actually crack and fissure and cause ulcerations. And this can be portals of infections where you can get cellulitis of your lower extremities, and these are risk factors to limb loss. This is an image of a callus, which is a central cord callus. Those are often very painful and need to be removed periodically, often caused by the bones beneath due to increased pressure. In the upper right-hand area is a fungal nail, And this is very well involved, and you can see the fungal spikes and the yellow subungual debris, and actually the tinea around the nail. And in the lower screen is an example of some actually really progressed hemosiderin deposits from vascular disease. As we grow older, we lose our muscle mass. And so when we were young and buff, we were big and strong. And as we age, we lose about 10% per decade. And that's usually after about 35 or 40. And it is a part of the aging process. And so this weakness changes our foot and foot function. Bone is turned over about every 7 years, and we lose about 10% per decade after age 40. Women, of course, are much more sensitive to this than men due to their menopause. And so it should be any young woman's desire to increase her bone mass as big and much as she can before the age of 40 by exercise, calcium, vitamin D, and good health. Because by 40 or 42, when they hit menopause, it deteriorates at a steady rate. And the higher up they are and the more bone mass they have, the more they'll have throughout their life, and the less chance of having fractures or stress fractures. Some nerve injuries that we often see in the foot are pinched nerves in the forefoot. And one is common where the medial and lateral plantar nerve communicate in the third interdigital space there, and we call them neuromas. And due to chronic pressure against that nerve from the bases of the proximal phalanges, it makes a nerve that should be the size of a pencil lead, the size of a pencil. And then that pinches even more, causing a great deal of pain. And once you get them lit up and inflamed, it takes about 2 or 3 months for it to calm down. Part of dealing with this is wearing wider shoes. And as we get older, our feet do get wider. So the need to size your shoes in an older age is vitally important. I don't wear the same width of shoes that I wore when I was 25. My foot has changed significantly, and I'm 66 currently. So as we get older, our foot splays. Also, repetitive trauma can cause arthritic changes, inflammation, and changes with strain. We often gain weight through our later years, and this causes increased stresses to the lower extremity. Some of the things that can include is the stress fractures due to weakening bones, once again, especially in females. And there are other risk factors for osteoporosis, smoking and drinking. There's tendonitis, which is excessive stresses on our tendons and ligaments due to our foot weakening and changing. We often see this in the form of plantar fasciitis and Achilles tendonitis and posterior tibial tendon dysfunction. So we see a lot of that. Digital deformities or hammer toes often happen due to imbalanced flexors. The flexors dominate and the extensors then weaken and hold it and contract. And then joint swelling and degenerative joint disease, rigid joints and spurring in the joints are all part of the repetitive trauma and inflammation scenario. Rheumatoid arthritis is the first one we'll talk about, and that is a seropositive disease entity. And when I say that, I mean 80% of the time they can identify a factor in the blood that is an anti factor which sees your joint as foreign and tries to get rid of it. So your immune system is seeing you or part of you as something that doesn't belong and wants to get rid of it. So it destroys the synovial lining. And what we see in that is degeneration of the cartilage, because the synovial lining produces the food for the cartilage, the fluid that it has nutrients in that keeps it alive and well. And you'll see joint space narrowing like the bottom right picture, and you'll see dislocation of the toes in the left picture where it says rheumatoid arthritis. Those are from weakening of the joint. And on the fifth metatarsal, you can see how the head is deteriorated and cystic. They become very weak. And a cyst in the second metatarsal head is almost pathognomonic for rheumatoid arthritis. Post-traumatic arthritis due to fractures. This individual has had a fracture. You can see the hardware up above, and they've had a triple arthrodesis. All three of their rear foot joints here have been fused, and that could eventually lead to wearing out of the ankle joint. Osteoarthritis, vascular disease, and there's a pathophysiological cascade where it's a wear and tear, causes inflammation, free radicals. It includes accumulation of factors that promote degeneration of the articular cartilage, and then more vascularity, which takes away bone, and you'll get cystic changes of bone and joint degeneration. So when we go see a patient, we think of their history, what their history has been, their past activities. Were they athletic? Have they had injuries, old ankle fractures and things like that? And those are all important in what's going on. Neurological exams are important because they play a large role in the foot function. The most common thing we see neurologically is diabetic neuropathies. And most of these neuropathies, especially the onset of sensory neuropathies, can be seen as diabetic or idiopathic, and vitamin Bs are vitally important in treating these because they're usually the only thing that actually helps the neuropathy. All the other drugs mainly mask it and make you feel a little better, but they don't help the neuropathy at all. And so we do a sharp, dull, and sometimes vibratory test on them. And we look at joint positions, and we use monofilaments at times to test that. We check the vascular supply, and we do that by feeling the arteries, and we grade those. And then we look at the skin and the skin textures, and we talked about the dryness and some of the skin things. Foot types are very interesting because there are many types of feet. There are flat types, there are cavus types, there are normal types, and then there are flexible flat foots, which are all kind of grouped into the biomechanical area. And strength plays a big role in the flexible flat foots. As we grow older, you'll see increasing posterior tibial tendonitis, and oftentimes people will flatten their feet due to it. And that is due to strength. So we also do studies. We do x-rays for bones, ultrasounds for some soft tissue, problems, Dopplers for arteries, and MRIs for soft tissue. When we go through treatments of xerosis, it's basically lack of moisture or hydration in your skin and loss of your natural oils, which I talked about, and sometimes keratin dysfunction. I usually start with oil-based moisturizers because that's what your skin normally uses. And there's some mineral-based moisturizers I commonly like. One is Eucerin. If that doesn't work, I step up to the ammonium lactates, which they have a tendency to draw moisture out of the lower layers of your skin to the upper layers, which are dry. And if you have really bad dryness, then urea creams I use. Nails, we often see the onychomycosis, and it can be chronic, and you can get tinea of your skin from your nails, and your skin can give it to your nails, and your nails can give it to your skin. So once you get it, you've got it. You got it because you can get it, and that means you're susceptible. And so if you have it, you need to treat it for the next rest of your life. Otherwise, it'll recur. And so I usually go through a system of telling people that if you're going to treat it with oral medications, it's a 3-month duration of taking the medications. It won't correct dystrophic nails, which are from heredity, but it can take the fungal nails away. This will return in 2 years if you do nothing more. And so you have to use a topical after that for the rest of your life to keep it away. Ingrown nails and paronychus, many people have severely incurved nails. Some of this is hereditary. And so you may have gotten it from your mom or dad, and the shape of your nail won't change with treating just a fungus. So sometimes we do procedures to remove the nail borders and get rid of the parts that ingrow, leaving you with your central portion of nail. So you still have a cosmetic and functional nail. And then sometimes nails get hematomas. And that's a black dot you'll often see underneath your nail. And this is from rubbing in shoes. We see it in running a lot, and we see it in people who don't tie their shoe gear, and they slide in their shoes back and forth. And it may be almost unnoticeable, but it rubs the nail and they get subungual hematomas. Flat foot, cavus foot, bunions, hammer toes, and degenerative joint diseases are all things that commonly affect foot arthritis and foot pains. These are common maladies. We look and see if there's a flexible or a rigid deformity. Pes cavus can often be rigid. Pes planus is often very flexible. Bunion deformities usually evolve from a flat foot and a flexible foot and heredity. Hammer toes, often from cavus feet. And degenerative joint disease from flattening of feet. So conservatively, we use orthotics, we often pad, and we debride callous skin. Orthotics can play a really good role in a lot of foot maladies that cause foot pain, ankle pain, and degeneration of joints. Surgery is always a last resort. You can always do surgery. So we try conservative things first, and if they fail, then you become a surgical candidate. We use orthotics quite a bit for flat foot deformities to stop the pronation and increase arches. so that it will increase function of tendons, posterior tibial tendon, and increase your ability to ambulate without pain. It also stops the abnormal motion in the joints that causes ligamentous stress and pain. This is an example of a flat foot deformity. And on the right, there's an example of how claw toes or hammer toes appear without all the flesh around it. On the bottom, an example of the bursa and back at the Achilles tendon, where people get Achilles tendinopathy. We call them enthesiopathies, where the tendon attaches and it causes a great deal of inflammation, bony spurring, and often tendocalcinosis. That tendocalcinosis often lays down a big lump of bone, and this can then rub in shoes and sometimes has to be removed. Correcting bunions, it's the only way you could do it is surgical, and we do it by reducing the intermetatarsal angles between the first and the second, depending on where the area of angular deformity exists. And then we remove the bump, straighten out the joint, and make sure it looks forward. So on the left-hand side or the right foot there's a large bunion deformity. On the right-hand side, it is corrected. In the picture on the right with the young individual standing there in an orthotic and one without, you can see what we call a valgus deformity of the rear foot, the outward tilt of it. And when they're in a orthotic, their leg is nice and straight. So sometimes orthotics, something as simple as that, can correct the deformity and correct the function. Usually these are also associated with tight Achilles tendons, and stretching is imperative. We'll go to heel and arch pain. And that's a whole chapter, almost a whole book in itself, but what dominates heel pain is mainly plantar fasciitis and fasciosis. Very interesting phenomenon. Used to think it was always due to being overweight, and that was really only part of it. There was a guy who did a study. I'm ashamed to say he was not a foot and ankle surgeon, but he did a wonderful study, and actually a brilliant study. And he studied fasciitis, and he compared people who were overweight to the normal population and people who have tight ligaments and tendons to the normal population. And he found that if you are overweight, you stand a 2.8 times greater chance of having plantar fasciitis than if you were normal. But if you have tight ligaments and tendons, and he determined that by hamstring tightness, you stand a 7.5 times greater chance of having that than the average population. So what it really said was what we were thinking for years and years and years was probably not entirely true. And what was even more true was it was due to the tightening of our ligaments and tendons as we grow older. And we know that happens, and we've known it from our trauma service due to ruptures of the Achilles tendon. In our Vietnam experience of men jumping out of helicopters, we saw increased incidence of Achilles tendon ruptures. And the most common age of this is 39 years old. At 15 years old, I don't think I've ever seen one except once in my life for trauma, because young kids are so flexible. But at 39, the stiffening process has happened such that it does relate in the form of injuries due to fast trauma. we have lost the elasticity in a lot of our ligaments and tendons. And instead of stretching and coming back to form and absorbing shock and energy, they tug, tear, and pull. And this causes fasciitis, it causes tendonitis, and it causes many of those things. So for this reason, the NFL partakes in yoga during their off season, and they found this decreases many injuries and increases flexibility of their players as they grow older, increases their playing life as well. Neuritis of the medial calcaneal nerve is not uncommon when you have a flat foot deformity, and it can cause arch pain because your arch collapses and stretches that nerve and actually sits on it. Bursitis of the heel, we already talked about, where the Achilles tendon rubs against it. Fibromas, which are tears of the plantar fascia, and they don't stop healing. They keep laying down scar. Sometimes can be confused with slow-growing sarcomas, but they are not. They're fibromas. And if they're painless, we often leave them. If they're painful, we can treat them or remove them. And we spoke of arthritis due to pain in the rear foot heel, and fat pads thin as we get older, and sometimes that causes a great deal of pain, including calluses. Here's an image of plantar fasciitis, and many anatomists believe that the plantar fascia is continuous with the Achilles tendon, and it's this white band you see here. And they believe the Achilles tendon fibers actually come all the way around and through, but the tearing here and pulling at the heel irritates the bone covering. The bone covering then lays down new bone, and you have the heel spur, which is a result of it. We see spurs all the time. Many times people don't have pain. Sometimes the medial branch of this tibial nerve comes through here and causes a great deal of pain. And so we have to look for neuromas here as well. One of the new things, and it's not so new, but insurance companies still don't like to cover it because they say it's investigational. It's pretty well proven, is the role of PRP. And these are platelet-rich proteins. And these are proteins that are found in your blood platelets, and they're healing factors or growth factors. And so we could take your blood, we could spin it out, and we could extract these proteins and inject it in you. And it often helps tendinitises and bursitis and things like that. And so it is a positive treatment modality. Now we can fall into diabetes. And diabetes has a high incidence of amputations for a number of reasons. These reasons include neuropathy. This patient has a hole in his foot, and he doesn't feel it. He could walk on that all day and not know it. Walk on that until the bone is protruding through it, not know it. So neuropathies, and then peripheral vascular disease and infection, which can spread to cellulitis and involve his whole leg, can definitely take his leg. So diabetic foot care is essential so that we pick these things up early and treat them as best we can and try to turn this around. With diabetes, insulin, of course, is the problem in getting sugar into the cells of your body. Requires insulin. It's the key that unlocks the door that the cells enter. And so your body literally is starving in a land of plenty. You don't get the sugar in your cells to metabolize, but it's all around them and can't get in. And this eventually causes vascular issues, neuropathies, dermopathies, atrophy of muscles, ulcerations. And so the key here is a team approach in treating diabetics, which includes rigid diabetic control by their family practice physicians or endocrinologists or internists. Vascular issues must be treated by the interventionalists, the cardiologists who open their arteries and actually salvage their limbs. And then wound care people like ourselves, and correcting bony deformities are all part of treating the diabetic foot.